What is the patient increased risk of?
Osteosarcoma,
And AV fistulas, heart failure.
heart failure, high
Very
cardiac output failure.
Okay. Patient that has sickle cell on steroids or alcoholic presents with hip pain, medial femoral circumflex artery insufficiency. What happened? Very good. Very good. Young male with bony projection of metaphysis covered by a cartilaginous cap. What's that?
Osteochondroma.
Very good. Osteochondroma. Male with bone pain, worse at night, pain relieved with NSAIDs.
Osteoid osteoma.
Osteoid osteoma. Very good, Elma. Yes. Hadizia, very good. Okay. Young male with bone pain, not responsive to NSAIDs. What's that?
Osteoblastoma.
Very good. Benign tumor of cartilage in hands and feet.
Chondroma.
Okay. Name me 2 tumors which are occurring in the diaphysis. What are they?
Ewing's.
Osteoblastoma. Very good. Very good. DO. Diaphysis, Ewing, and osteoidostoma, DEO. DO. All right. Okay. Benign tumor of, okay, so knee pain, X-ray shows slow bubble appearance. What's that?
Cancer
GCT.
Very good. Child with retinoblastoma, loss of red reflex in the eye is known as retinoblastoma. All right. Develops bone pain. Elderly male with Paget's develops bone pain. Retinoblastoma.
Osteosarcoma.
Very good. Retinoblastoma, P53 mutations. Imaging will show Codman triangle sunburst pattern. Very high yield. All of the points I'm saying, very high yield. Already remember that. Okay.
Yes.
Tumor at diaphysis, X-ray shows onion skin.
Ewing
sarcoma.
Onion skin.
Very good. Okay. Middle-aged female with greater than 1 hour of morning stiffness, symmetrical ulnar deviation of the hand, lumps on hand or arm. Imaging shows erosion of the bone. What's that?
Rheumatoid arthritis.
Very good. Okay, so elderly female with joint pain, worse with activity, bone deformity of DIP and PIP hand joints. Imaging shows
Osteoarthritis.
Exactly. So what will you see? What are the lost symptoms? What will you see?
Swellings.
So you will see
Involvement of distal interphalangeal joints is the main thing.
Hamilton and Bouchard nodes.
And also the swellings, Herbert's nodes, and the Butcher's nodes.
Very good. Okay, so I will say that you will have loss, which means that you will have loss of joint force, osteophyte formation, subchondral cyst, and subchondral sclerosis that occurs in the patients with
Osteoarthritis.
Very good. Another giveaway for osteoarthritis and rheumatoid arthritis is this. Usually rheumatoid arthritis will be in young females, and osteoarthritis will be usually in type of old females, and they will sometimes also mention osteoarthritis of hands. So it's not necessary that they will give you a knee joint. They can also give you osteoarthritis of hands. All right. So that you need to be able to differentiate between RA and osteoarthritis. Why is it RA? Why isn't it OA? They can give you a patient with a similar age group as well, and they can ask you about, oh, it's a 35-year-old and she has osteoarthritis of the hands. They can do that. All right. So be very particular with the image presentations as well. All right. Patient with sudden pain and swelling in big toe, needle shaped. What's happening?
Gout.
Okay. First, you always treat with NSAIDs for pain. Then you treat allopurinol for long-term. NSAIDs you don't give in patients with kidney disease. So if a patient is having kidney disease, NSAIDs contraindicated. What will you give? You will give colchicine. Give colchicine or give steroids. All right?
Okay.
Okay. Patient with hemochromatosis develops sudden pain and swelling of knee. I told you guys this. What's happening? Rhomboid shaped positive bifringence. What happened?
Pseudo-gout.
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 Very good. Pseudo-gout. Hemochromatosis, primary hyperparathyroidism, both can cause pseudo-gout. All right. Very high yield for you to remember this. All right. Okay. Let's go to the middle-aged female complaining of increased need for eye drops and new dental cavities, increased risk
Sjogren's
of.
syndrome.
Sjogren's syndrome.
Very good. You
Syndrome.
have a red hot swollen knee. What is the next best step?
Depression.
Intraarticular
Septic
steroids.
arthritis. Septic arthritis, but what is
That's right.
So you ask the manager.
Synovial joint analysis. Whenever you have a red hot swollen joint, the first step is always synovial joint analysis, so synovial fluid aspiration. All right, I told you guys this. You will never treat it first, even if the patient is dying. You don't care. You will first aspirate the joint and see why is the pathology happening. In septic arthritis, you will see WBCs in very higher range, 30,000 to 40,000, 50,000 WBCs. In osteoarthritis, usually the limit is very less. All right. Every joint pathology can cause septic arthritis. I've been telling you this over and over again. All right. Okay, so you have joint pain, silver scaly plaques on elbow and knees, nail pitting. What's that?
Psoriasis.
Psoriasis.
psoriatic arthritis?
Very good. Joint pain after recent sore throat and fever, trouble seeing and urinating. What's that?
Reactive
Reactive
arthritis.
Reactive arthritis.
Very good. 22-year-old patient with low back pain resolves with movement. X-ray of the sacral spine shows fused vertebra. What's that?
Ankylosing
spondylitis.
spondylitis.
Very good. Ankylosing spondylitis. What is the treatment for ankylosing spondylitis? Exercise. You will tell them
Exercise.
to. Very good. You will treat. Steroid is usually the last treatment.
Yeah.
I mean, why is everyone hell bent on giving every patient steroid? First, wait for the patient, to kind of respond to conservative measures and dietary changes, and then only in the end we give steroids. So, steroid is not always the answer for first. Whenever they ask you initial treatment, it will never be steroids. It is always a last resort. All right. Okay. So, a 33-year-old female with joint pain, rash, lab stool, low hemoglobin, high creatinine. What's that?
SLE.
SLE. Very good. It's SLE. Okay. Recurrent pregnancy loss and new DVT in left leg, high PTTT. What's that?
Phospholipid.
Very good. Stiffness in shoulders and hips, high ESR and CRP quickly resolves with steroids. What's that?
Polymyalgia
rheumatica.
rheumatica.
Very good. 45-year-old female with chronic pain in neck, shoulders, knees, and feet, poor sleep, but ESR is okay.
Fibromyalgia.
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 Very good. Trouble walking upstairs and getting up from a seated position, endomysial inflammation. What's that?
Polymyositis.
What if it would have been a perimysial inflammation? Then what?
Then dermatomyositis.
Dermatomyositis.
Very good. Painful lump in the muscle after getting injured in a soccer game. What's that?
Myositis.
Myositis.
Very good. You guys are doing great. Muscle weakness, worse with repetitive activity and end of the day. Double vision, drooping eyelid. What's that?
Myasthenia gravis.
Very good. Elderly male smoker with weight loss and chronic cough now has muscle weakness that improves with activity. What's that? Very good. Very good, Margaret. Very good, Ramis. Very good, Rebecca. Very good, Devanshi. Very good, Elma, Subira. You all are doing very great. Okay. 45-year-old female has heartburn after eating and fingers turn blue and cold. What's that?
Raynaud's
phenomenon.
Exactly. Where is it happening? Heartburn after eating. What's
in the
Summer.
CREST syndrome.
Crest syndrome. Sorry.
Okay. Where do you see CREST syndrome?
Limited
Scleroderma.
Scleroderma.
Raynaud's syndrome.
This time,
Very good.
yeah.
Okay. Where do you see Klumpke's palsy? What injury?
Lower trunk injury. Lower trunk.
Yes, it's lower trunk injury.
Lower trunk injury.
T8 to T1.
Very good. What if there is atrophy of the hand muscles, extra cervical rib, compression of the scalene muscles? What's happening?
Classic
Thoracic
outlet.
outlet
Thoracic
syndrome.
Classic outlet syndrome.
Very good. Fall on outstretched hand, pain by the thumb can cause avascular necrosis. What fracture?
Scaphoid.
Scaphoid.
Good. What other thing it can cause?
Also the
Or
fracture of the clavicle.
No,
And
the
the
scaphoid fracture has two complications. One is avascular necrosis, the other is
subluxation.
yeah.
Carpal tunnel.
Lunate
Lunate subluxation.
lunate subluxation.
it is non-union. I remember I was
Non-union.
Oh, yeah.
non-union. First is that avascular necrosis, and the other is non-union. Two high yield, complications. They will be asked you in your UWorld self-assessment as well. So it is important you know that. Okay, injury of hand after a fall developed carpal tunnel syndrome. What happened?
Median nerve injury.
Lunate
Lunate
dislocation.
Very good. It's the lunate dislocation. Unable to extend medial two fingers. What happened?
Medial.
It's the
ulnar nerve
Ulnar
injury.
Nerve
Ulnar
involvement.
nerve injury.
Oh, no, no.
Very good. Okay. Can't extend lateral fingers.
Median.
Median nerve.
Median
Median
nerve
nerve.
injury.
Very good.
Doc,
Okay.
will it be like can't extend or
Maybe
can't
it's still
flex?
median nerve injury. It's called the median claw. It's not high yield, but I just threw it as a distractor. It's because of when you cannot extend the lateral fingers, it's due to the distal median nerve injury. It's called the median claw. It's not important if you don't want to remember it. It's okay. All right. Burning, tingling in suprapubic region after abdominal surgery.
Iliohypogastric injury.
Very good. Decrease sensation to medial and anterior thigh, absent cremasteric reflex. What happened?
Genitofemoral nerve.
Genitofemoral. Yeah.
Female with 75 BMI has decreased sensation to anterior and lateral thigh.
Lateral
Lateral thickness nerve.
Malgia prosthetica.
Very
Yes.
good.
Melangia.
Okay. Unable to extend leg after car accident causing anterior hip dislocation, decreased patellar reflex, leg externally rotated.
Femoral nerve
Femoral
injury.
nerve
Femoral nerve
injury.
injury.
Very good. What if the leg is shorter and internally rotated?
Fracture of the hip.
Sciatic nerve injury.
Sciatic nerve injury. Sciatic nerve. Yeah.
Very good. What if there is trauma to the lateral leg, unable to pick up foot while walking or feel top of the foot? Foot drop.
Common femoral.
Common
Common femoral nerve injury.
Very good. Patient with injury to the knee or ankle, unable to stand on tiptoes or feel sole of the foot.
Tibial nerve
Tibial
injury.
nerve
Tibial
injury.
nerve.
Tibial nerve, yeah.
Very good. Patient given an injection to supramedial gluteal region, standing one on leg leads to pelvic dropping.
Superior
Pendle
gluteal
nerve.
nerve.
Gluteal
Yes.
nerve injury.
Standard back sign.
Superior gluteal nerve injury.
Very good. That's a superior gluteal nerve. Patient with posterior hip dislocation, difficulty climbing stairs.
Inferior gluteal.
Inferior gluteal. Very good. Decrease sensation to genital. Okay, I think we did that, right?
Pudendal nerve
Okay.
injury.
Yeah, we're done. I have just 5 more questions for you guys. All right. There is this boy, ski accident happened. On examination, there is widening of medial joint line when gentle force is applied to the lateral knee. Which structure injured?
Medial. Medial collateral ligament.
Can you please repeat?
Can you repeat it, Dr. Maheen?
Yeah, I can.
Can you repeat? Yeah.
So it was.
Can you repeat the question?
Can you repeat,
once more question?
Dr. Maheen? Can you repeat?
Sure, I'm just okay. Yeah, boy, ski accident. On examination, widening of medial joint line when gentle force is applied to lateral knee. Which structure is injured?
MCL.
Medial collateral injured.
Very good. That's the medial collateral, and we are okay. What do you mean by prepatellar bursitis? What's that?
Housemaid knee.
Outrage because of
Shock absorber.
Okay.
Because of
For
repetitive injury,
people prolonged kneeling,
overuse, or the
Overuse.
kneeling. Yes.
Okay, name major hip flexors, extensors, abductors, and adductors. Come on, who is going to raise their hand and tell me? Come
Hip
on.
adductor.
Yes, Dr. Inaya, you tell me what the hip flexors are.
The hip flexors are iliopsoas, rectus femoris, sartorius.
And
pectineus,
yes, hip flexors are iliopsoas, rectus femoris, and
Sartorius, pectineus, and tensor fascial lati.
tensor fascia lati. Yes. All right. Who is going to tell me the hip extensors? Yes, Dr. Harshini, I see your hand is raised. Hip extensors.
Yeah, gluteus maximus,
Mhm.
semimembranous, semitendinosus,
And
biceps femoris, long head.
very good. Okay, Ramiz, yes, you tell me what are the abductors.
Gluteus medius and minimus.
Very good. Okay, last, Dr. Rifat, you can tell me what the adductors are.
Adductors are adductor magnus, longus, and brevis.
Very good, guys. Very good. Keep it up. Okay. So I think we are done for the day. Okay, just last question I'm going to ask you. Young male, pain in the right buttock and posterior thigh, forced adduction of flexed thigh and internal rotation of the extended thigh causes pain. Entrapment of sciatic nerve at greater sciatic foramen is expected. Which structure occupies that foramen?
Piriformis
Piriformis.
muscle.
Piriformis muscle.
Piriformis muscle.
yes.
Yes. So we know that the piriformis, it passes through the greater sciatic foramen and it is involved with external hip rotation. We also know that if there is any muscle injury or hypertrophy, it can compress the sciatic nerve in the foramen and can cause piriformis syndrome. All right. Okay, guys, we are done for the day. We just had a rapidly interactive session for today. You guys are doing great. Yes, Dr. Devanshi, what is your question?
Ma'am, the vascular smooth muscle contraction and relaxation theory and neuroaction potential, are those important?
The neuroaction potential, so the physiology questions are very like lower yield for the USMLE step one. Mostly they ask you about pathology. They don't ask you about physiology that much, but it is okay if you kind of go through the concept about how the muscle is contracting, what are the the filaments doing, where is calcium contraction happening. Just be familiar with the physiology. They're not high yield, but just go through that.
Okay. Thank you. It
All
was
right.
wonderful today.
Thank you, guys. I just did this in like a span of like 5 to 10 minutes. Dr. Hamza told me that the students want to delay the assessment session for tomorrow. So I said, okay, let's not waste the time because I know how important it is that you guys are, working for your step one. Some people have their step one in the next month as well. And I want every second of it to be put into the studies. All right. Okay, I will share the questions on the group. Do not worry
Okay.
about that. People who have, who don't, who didn't attend the session, I will be sharing the questions on the group. You guys can go through that. It was a lovely session. You guys are doing amazing. You are great at where you're standing right now in terms of your preparation. I see nothing that needs to be changed as of now. You're doing great and continue with that. All right. Okay, guys. So I'm going to be leaving this session. Dr. Emma is going to send the another link for that. Okay. All right. I think somebody's mic is on. Dr. Harshini, is it your mic? All right. Okay. So I'm going to be leaving the session. Dr. Emma, Dr. Hamza are going to share another link. If there's a session or not today, I don't know. But they will inform you guys. You guys can leave the meeting. It was a really great, wonderful session. Keep up the good work, guys. All right. Bye-bye.
Thank you, Dr.
Bye. Bye.
Thank you.
You're welcome, guys. You're welcome.
build a plan is patience. I was on a flight from Mumbai to Kyoto when I suddenly had the idea for a new story. Koveda. I could not sleep that night. So excited. As soon as I reached, the first thing I did was search for manufacturers. Then, the first step was formulation. Then the trials for months with hundreds of samples. Then the required certification and testing for safety. Then, after a year, the final production and grand launch. From the idea to reality, the journey has been a fun roller coaster ride. Can't wait for you guys to try the product. March 20.